Hi, Vivek. This is Dr. Zishan. How are you?
Good afternoon, Dr. Zishan. All well? How are things? Everything on time, or we are waiting a bit?
No, so far normal. Probably 5 minutes delay would be with this session. We'll start probably somewhere around probably for 50, 450. We plan to start with 4:45. So
Great.
3 to 5 minutes delay may be there.
No problem at all. That's good going. Fine. So my request was that if my recording could be played, and I'll answer the question answers as and when they arise during the after the
Perfect.
session.
Perfect.
I'll be there.
I will be playing your recorded talk, and we'll take questions after that with you live. So Professor Jalan would also be there, and probably we'll have the Q&A at the end of the session.
Sounds good. Thank you.
Okay. Hi, Rajiv. How are you?
Excellent. Hi, how are you?
That's great to see you. And last year as well in Karachi. We are probably we are regathering the audience. We had a break after the last session, so it will take 5 more minutes to start with. And Dr. Vivek is here.
Hey, Vivek. Hi. Nice to see you.
Hi, Rajiv. Same here.
Across the globe.
Yes. I think this is the new normal, and it has a lot going for it. So you
terrible
any
new
number
normal.
of meetings and top faculty always there on the meetings, because I think traveling and all those hassles are set aside. So
You
overall,
like it?
it does seem to be adding to the quality of meetings, at least in our part of the world.
Do you actually like it? I think it's soul destroying, because if you wanted to do this, you might as well just go onto Zoom and found some YouTube videos or do some reading by yourself.
Right.
I don't know. That's what I think anyway.
Yes, that indeed. I think, lots of guys have their YouTube channels and stuff loaded on for years there. So all you got to do is to just at your convenience, switch it on.
Yeah.
Right. The live interaction bit of it is something that's taken a hit. And yes.
But this
I think
is
it
all
must-
the pain. There's no gain, you know.
uh,
This is all the pain. You still prepare and you still present and all this sort of stuff, and you still have to be there. And but it's not, you know, there's no fun.
Absolutely. I think I've been a couple of times to Karachi, and it's always been a wonderful experience traveling to that part of the world for us. Similarly, Europe and elsewhere. I think that is a big part of giving these talks. Otherwise, I think, I guess, yeah, you're quite right about what you're saying. It becomes a very kind of a hands-off, very professional sort of a thing. You just kind of deliver and switch off to and do something else 15 minutes later.
Exactly.
Not the fun of attending a meeting.
Yeah, exactly. So you're not actually focused on anything, you know. You've made no relationships, you've learned nothing because you're not going to sit at the meeting. You've gone there, done whatever it's going to do, and you've gone. But you still spend hours preparing a talk or whatever. And then, you know, and the people where you're going to have no chance to interact with you.
Right.
Because ultimately the point is that, you know, you want to grow your collaborations and, you know, meet people and stuff. So I find it impossible. I really hate it, you know.
Well,
And
yes,
you cannot ever say no to anybody. You see, you always accept because
yes.
somebody asks you, let's say 6 months, 9 months in advance, and you say, yeah, of course I can do it.
Yeah. And I guess, I mean, one still hopes that this is going to be just another matter of another 6 months now with the whole globe vaccinated.
Yeah.
But I mean, the mutants are thriving now because transmissions are going on in our part of the world. And I think newer and newer mutations are emerging. So I don't know where we'll see the end of this and get back to normal face-to-face meetings. Hybrid meetings is what is becoming fashionable now.
The hybrid is also okay, but pure online is difficult, I think.
Yeah.
You know, it is a new normal, as you say.
No, I mean, going to a meeting, one of the big things is you're there for 2 days. And I mean, there's only so much sightseeing you can do when you're going back to the same venue again and again. So per force, you kind of sit through the meetings, and that's when a fair bit of learning happens.
That
You're
is
listening to very high quality talks from good people.
Yeah.
So I think that bit we are missing because here, well,
On.
Okay.
Sorry to interrupt you,
Please
but
go
we are
ahead.
going to start with our session now.
Okay.
With this, we come to the end of our today's session. This is going to be the last session. Of course, we have a workshop regarding the research after this. For this last session, we have the theme, which is acute and chronic parenchymal and vascular injuries of the liver. And for the panel of experts, I would like to call my teacher and teacher to many here, a role model, Professor Dr. Altaf Alam, ex-head of department, Sheikh Zayed Hospital, Gastroenterology Department. Sir, please. And with him, we have Professor Dr. Nasibullah Shah, who is the head of department of medicine in the Bolon Medical College, straight from Balochistan, Quetta. Okay, so Professor Nasib will join us shortly. Let me introduce you to our speakers today. First of all, we have the speaker from India, Professor Vivek Saraswat, who is with us right now, live. And he is going to talk about hepatitis E, all we need to know. And he is MD, DM, and head of department of Sir Gangaram Institute of Medical Sciences in Lucknow. And he's doing that for last 28 years, heading the department. And also his areas of interest include the biliary ESWL and esophageal manometry. So we are going to start with a talk by Professor Vivek Saraswat. Sir.
If you could please play the recording that I had sent earlier and that had been done, and I'll...
Yes, sir, we are going to play the recording.
Thank you, Mr. Chairman. Good evening, ladies and gentlemen. I bring you greetings from the Sanjay Gandhi Postgraduate Institute in Lucknow, Uttar Pradesh, India. At the outset, I would like to thank the organizers of this meeting, particularly Professor Kashif Malik, Professor Javed Farooqi, Professor Altaf Alam, and Professor Bushra Ali for giving me the opportunity to speak at this important meeting. I've been asked to speak on the topic of hepatitis E virus, all you need to know. I wish the organizers had been equally generous with the time that they're allotted to me, but nevertheless, in the next 20 minutes or so, I will try and take you through as much of the topic as time will allow. First, briefly about the history and the geography of this virus. To trace some of the key events in the history of this virus, in modern times, the first major outbreak of infectious hepatitis is the one that was reported from New Delhi in 1955-56 and was found to be not hepatitis A or B. However, the seminal work on identifying enterically transmitted non-A, non-B hepatitis as a new virus was done by Professor M.S. Khuru during the Kashmir Valley epidemic in 1978, who also noted the high mortality in pregnant women. M.S. Balayan et al. In 1983, 2 years before similar work was done by Barry Marshall for Helicobacter pylori, actually ingested a suspension of prepared from the stool of patients infected with this enterically transmitted virus, developed an acute hepatitis, and identified virus-like proteins from his own stool during the Afghanistan epidemic. Subsequently, sequencing of the viral RNA genome reported in 1990 led to an explosive growth in the field of hepatitis E virus research, including the development of HEV genotyping in 2006, initially 4 and now 8 genotypes have been described. The first vaccine was reported in NEJM in 2007, while in Lancet 2010, the phase 3 trial of Hecolin, which became the only approved drug in the world, was reported. And in between, in 2008, Nisim Kamar and co-workers reported the occurrence of chronic hepatitis E virus infection with genotype 3 infection. There are many, many more important landmarks, but for the want of time, I have confined myself to these. Now, looking at the global distribution of hepatitis E virus, the regions shown in blue are hyperendemic for this virus. Those shown in red are low endemicity areas, and green areas are reported as non-endemic for the virus. These roughly coincide with genotype 1 and 2 distribution in hyperendemic and genotype 3 and 4 distribution in low endemic areas. In hyperendemic areas, large epidemics from time to time have been reported, including the important epidemics I have listed in this box, the largest one being from China. In 1991, at our own institute, we investigated the outbreak in Kanpur affecting roughly 79,000 individuals. This cartoon shows you the numerous other smaller epidemics that have been reported, as you will see, mainly from northern India, north of the Vindhyas. And overall, the global burden is of roughly 20 million infections per year of acute hepatitis E infection, 3.5 million of which are icteric, resulting in about 70,000 deaths and 3,000 stillbirths, with 1/3 of the world's population having a lifetime risk of developing this infection, which may be as high as 60% in endemic areas. Now, coming to the structure and the genome of the virus that was first discovered in 78 and identified in, say, 1983. This is the immune electron microscopy pictograph showing you what the virus looked like under the electron microscope. Diagrammatically, it is being seen as a 72 kilobase positive single-stranded RNA, which is quasi-enveloped, and the RNA is contained in an icosahedral capsid. It has 3 open reading frames. Open reading frame 1, ORF1, which contains 70% of the genome, codes for 5 enzymes and other important regions. ORF2 codes for the capsid protein, which secreted as monomers, eventually forms decamers that assemble in virus-like proteins without the capsid, and the full HEV virion enclosing the capsid and the RNA. The capsid protein binds to target receptors to infect cells, is the target for the immune response to HEV, and also serves as the basis for development of candidate vaccines, all of which are ORF2 based. ORF3 is codes for viroporin, which is important for viral egress from the human cell, while ORF4 is generally reported only in genotype 1. Some clinical and epidemiologic features: over 90% of infections with hepatitis E virus are asymptomatic, while fewer than 10% result in overt hepatitis B, while extrahepatic manifestations can be seen both with asymptomatic and overt infections. Fewer than 1% develop a complicated course with liver failure, acute liver failure, or acute chronic on chronic liver failure, mainly with genotype 1, while chronic hepatitis E and extrahepatic manifestations are mainly seen with genotype 3 and 4. Events during the acute infection with the hepatitis E virus genotype 1 are shown in this cartoon. After an incubation period of about 3 weeks, there is a prodromal illness of roughly a 1 week duration, followed by an icteric phase of about 4 weeks and a convalescent phase of about 7 to 8 weeks. The first biomarker to appear in the serum is HEV RNA. Viremia is short, lasting only about 3 weeks or so. Simultaneously with the appearance of the prodrome, IgM anti-HEV as well as ALT elevation is noted. While ALT comes down more rapidly, the course of IgM anti-HEV decline is slower, and IgG anti-HEV, which appears later around the 4th weeks, is long-lasting. Now, coming to some clinical features of different HEV genotypes. Genotype 1, we have already talked about its geographical distribution. Genotype 1 is transmitted mainly by contaminated drinking water. There is no zoonosis or animal reservoir for this infection. It is the most common cause of sporadic hepatitis, the cause of outbreaks in epidemic hepatitis, and fulminant hepatitis develops in 20 to 30% of women who are pregnant women who are infected with this virus. Genotype 2 shares similar characteristics, although it is less well studied. Genotype 3, we've already discussed, is mainly seen in industrialized nations. It is a foodborne zoonosis, mainly transmitted through inadequately cooked pork, as well as other food items, shellfish, strawberries, vegetables, also through blood transfusions. It is responsible for chronic hepatitis E virus infection in proportion of patients with immunosuppression, frequently develops neurologic symptoms like neuralgic amyotrophy. While genotype 4 has similar routes of transmission, it seldom develops chronic hepatitis. There is no clear evidence of neurologic involvement, but interestingly, it is associated with preterm births, abortions, and is associated with male infertility. The other 4 genotypes have been recently reported in small numbers. The animal reservoir is the wild boar in Japan. In the Middle East, it is the camel, both the dromedary and the Bactrian camels, and their detailed clinical profile and significance is still under evaluation. Now, coming to an important feature of hepatitis E virus genotype 1, that is its course during pregnancy. Higher rates of infection during pregnancy have been reported mainly for genotype 1 and 2, with only a few cases for genotype 3 and 4. Higher rates of infection in pregnant women compared to non-pregnant and women and men have mainly been reported from northern India and also from several other African countries, but not from Egypt. An important paper that came out in 2006 suggests that this may be because of the high seroprevalence of anti-HEV by the age of 15. Just like HAV in India, HEV has a 90% seroprevalence in Egypt, whereas the maximum seroprevalence reported from Indian studies has not crossed 40% and even lower in the juvenile age group, which may account for the higher infection rates in young women when they become pregnant. The conditions in pregnancy I'll talk to about, which predispose to infection, I'll talk to about very shortly. However, once acute hepatitis develops, the frequency and severity of fulminant hepatic failure is similar in pregnant and non-pregnant women. Management is conservative, and hitherto no evidence suggests that termination of pregnancy in acute liver failure decreases maternal risk. Here I've summarized some important studies in which the infection rates and the rates of fulminant hepatic failure and death are documented in HEV genotype 1 infection. The seminal study from Kashmir showed a 17.3% infection rate and a 22.2% mortality due to fulminant hepatic failure in pregnant women. Similar numbers are reported from other parts of India. However, the retrospective analysis of the study data sera stored in the Delhi epidemic were not as instructive. These two series from Africa show similar high attack rate in pregnant women, as well as high fulminant hepatic failure rates during pregnancy. There are many other similar studies which follow the same pattern, that the attack rates are 3 to 5 times higher during pregnancy than in non-pregnant women or men, and fulminant failure development as well as deaths up to the tune of 20 to 30% are 3 to 7 times higher in pregnant women. Now, what are the mechanisms underlying severe liver injury due to the HIV infection in pregnancy? Although only fragmentary evidences and data are available to flesh out our hypotheses, immunologic factors during pregnancy, the changed hormonal milieu in pregnancy, viral factors, as well as other factors like the nutritional status have been thought to play a role. As we all know, pregnancy is a state of immunosuppression where the adaptive immune response is weakened with a Th2 bias. Also, there are inadequate triggers for innate immune response, all of which result in impaired pathogen clearance. Similarly, greater immune injury may be the result of higher levels of cytokines seen in these patients, as well as the increased activity of nuclear factor kappa B complex and other pathogenetic factors. The hormonal milieu in pregnancy, that is the very high levels of estrogens and progesterones and HCG, is also important because estrogens have been shown to promote viral replication, where already there's impaired clearance. The viral replication also is amplified. It also results in placental insufficiency and the poor fetal outcomes. Similarly, mutations in the progesterone receptor, the progenes mutation, has been associated with fulminant failure, while reduction in the protective progesterone-induced binding factor may also play an important role. Viral factors are thought to be the most important. As we know, only genotype 1 and 2 cause severe disease in pregnancy, not genotypes 3 and 4. Multiple mutations have been associated with fulminant hepatic failure in various studies. However, the mechanisms by which they cause severe liver injury are yet to be fully elucidated. These are mutations in ORF1, 2, and 3. Some of them are shown here, and they result in blocking interferon activation, in increasing immune escape, increased apoptosis of hepatocytes, and increased survival of the virus within the hepatocytes, amongst other mechanisms. How do we manage hepatitis E infection during pregnancy? The standard drugs that have been used for chronic hepatitis E, as I will talk about, ribavirin and in some cases interferon, cannot be used in pregnancy, being category X and category C drugs associated with teratogenicity and mutagenicity. However, there have been arguments submitted that acute liver failure in the third trimester is a life-threatening illness for the mother at a stage of pregnancy when organogenesis is complete. And so ribavirin may be tried, but the first human reports of ribavirin during pregnancy are still awaited. Others have argued that in an explosive illness like fulminant hepatic failure, which often runs its course in 5 to 7 days, there may not be enough time for antiviral therapy to act. Once liver failure develops, ICU care with conservative management, prioritizing saving the mother's life, is the theme of management. As I have said earlier, no data support the hypothesis that termination of pregnancy alters outcome of HEV-ALF, unlike AFLP and other pregnancy-associated disorders. There have been case reports of successful liver transplantation for HEV genotype 1 fulminant hepatic failure, mainly from Japan and some from the US. However, prevention during pregnancy, vaccines have not been tested during pregnancy, although currently, as I'll come to later, phase 4 study in childbearing age women is ongoing in Bangladesh. Now, chronic hepatitis E virus infection, how does one define it? It refers to persistent viremia or fecal excretion lasting for more than 3 months following acute infection. It was first reported in immunosuppressed organ transplant recipients, liver and kidney transplants, and is almost entirely to genotype 3, never due to genotype 1 or 2, also seen with HIV infection, stem cell transplant recipients, rheumatologic and hematologic conditions. And it has been seen that up to 20 to 50% of acute HIV infection in liver transplant recipients become chronic. Presentation is often asymptomatic with mild LFT derangements. The virus is usually reliably detected only by nucleoside amplification testing, not by serology, and progressive fibrosis, cirrhosis, and decompensation within 5 years, if untreated, is often the outcome of chronic hepatitis E virus infection. There is no FDA or EMA approved therapy for chronic infection. Nevertheless, the EASL guidelines published recently have supported reduction in immunosuppression, which may result in clearance in up to 1/4 of chronic hepatitis E virus infection. Monotherapy with ribavirin 600 milligrams daily for 3 months may result in sustained virologic response in up to 78% patients. A second course clears some more patients when given for 6 months, but in 5 to 15% patients, there is a failure to clear HEV with ribavirin, and this may be related in some cases due to presence of a variant HEV polymerase mutation, as shown here. Adding interferon to ribavirin is also more effective, but cannot usually be used in transplant recipients, except in some patients with liver transplant who have had liver transplant. Sofosbuvir has been shown to have antiviral activity, but it reduces viral load and does not achieve a sustained virologic response in the small studies carried out till date. Newer drugs like interferon lambda, PPMO, HP1, 2CMG, etc. are being developed and are being investigated for chronic hepatitis E, while indigenous medicines with anti-HEV activity like silvestrol and babaudan need to be explored further. A brief word about extrahepatic manifestations, mainly seen with genotype 3. Neurologic symptoms are common, central and peripheral nervous system involvement, including neuralgic amyotrophy, a unique, very commonly seen in HEV3. Pancreas, renal and biliary tree involvement, hematologic and heart-related complications and other miscellaneous complications, extrahepatic manifestations have also been reported, while genotype 1 is the commonly associated with acute pancreatitis, including a small series we've reported from our center also. Now coming to the last leg, hepatitis E vaccination, where are we today? The first study is all you're familiar with, the seminal study that appeared in NEJM in 2007. It was a vaccine developed by GSK using recombinant baculovirus containing P495 segment of ORF2 from genotype 1 was studied in Nepalese soldiers and showed to have a high efficacy. Another phase 3 trial using the P239 sequence base pairs from genotype 1 ORF and genotype 1 ORF2 was studied in China in the largest human trial carried out till date, which included roughly 50% who already were seropositive for anti-HEV. 3 doses of 30 micrograms were administered, and at 12 months, 100% efficacy was demonstrated. More recently, a phase 1 randomized open clinical trial using P179 sequence from ORF2 derived from genotype 4, which is seen to assemble in virus-like proteins, is being studied and compared against the P239 vaccine. So as I've shown, all these vaccines are directed against the ORF2, which has 660 base pairs, of which 495, 239, and 179 all include the E2 segment, which is the most highly immunogenic of the sequences seen of the ORF2. The status of these vaccines is shown here. Only one, the Innovax or Hecolin, has reached been approved in China and has reached the stage of phase 4 studies. Why is this? What are the limitations of hepatitis E vaccination today? The gaps in our knowledge and vaccination strategy were outlined by the strategic advisory group of experts from WHO, who found that safety and efficacy data were lacking in key populations: children, elderly, pregnant women who have very severe disease, those with liver disease who develop acute and chronic failure very commonly, in immunosuppressed patients, and travelers to endemic areas. Further, there are no data on immunogenicity when it is given with other vaccines or its efficacy in post-exposure situations during outbreaks. Other important questions about protective titer, duration of immunity, role of boosters, cross protection, efficacy of shorter schedules, and what is the best strategy, universal childhood immunization in endemic areas or selective vaccination for women in childbearing areas, are many of the unanswered questions, some of which have been addressed in the more recent studies. For example, this large Chinese study showed that the efficacy of this virus in patients already having a chronic hepatitis B virus infection was just as good as in the other healthy individuals with high antivirus titers. However, antibody persistence that was reported recently in 2019 showed that antibody levels did wane with time, with 1/4 of patients with either naturally acquired infection or following vaccination losing their antibody by 6.5 years, more so in those who had naturally acquired infection. Also, animal and human studies do show cross protection for both the Glaxo vaccine and the P239 vaccine. Finally, as I mentioned earlier, this large study has been initiated in China, in Bangladesh, in women of childbearing age. In this phase 4 study, over 40,000 childbearing women in the age of 16 to 39 years have been recruited, given 3 doses compared with the hepatitis B vaccination. And the primary endpoint is going to be HEV disease in non-pregnant women. While the recruitment is over, results of this trial are eagerly awaited. So in conclusion, ladies and gentlemen, I would like to say that hepatitis E infection is a global problem with a heavy disease burden. It occurs in 2 forms, the genotype 1-2 and genotype 3-4 disease, which are both distinctive in their geographic, epidemiologic, and clinical pictures. Genotype 1 is the commonest cause of sporadic acute hepatitis, epidemics of acute hepatitis in the tropics, and is associated with high maternal mortality in pregnancy. Chronic hepatitis E occurs in 20 to 50% of immunosuppressed organ transplant recipients due to genotype 3, and which also has common extrahepatic manifestations. Treatment of chronic hepatitis B is mainly based on ribavirin, and other strategies are now being developed. Prevention with vaccines is possible, feasible, and has been studied in large populations. But until more data about specific target populations are available, its widespread use has not been recommended by bodies all over the world. And our understanding of pathogenetic mechanisms, development of diagnostic tools, and newer drugs and newer vaccines is progressing rapidly. I thank you very much for your attention.
Thank you so much, Dr. Vivek, for your such a nice elaborative talk. We are going to take the question answers at the end of the session. Next, we have another esteemed member of our international faculty with a talk on acute and chronic liver failure, assessment and management by Dr. Rajiv Jalan. He is a professor of hepatology and head of the liver failure group at University College London, and he's a consultant hepatologist at Royal Free Hospital in London. And he's an active researcher with 400 plus papers to his name. So over to you, Professor Rajiv.
Good morning, good afternoon. Thank you very much for this very kind invitation to come and speak to you today about acute on chronic liver failure. Here are my disclosures, none of which are really relevant to what I've got to tell you, but I'm passionate about finding new treatments for this condition, and a lot of my conflicts here are related to new therapies that we are hoping to develop in the future. So what I'm going to try and cover today with you is to try and indicate to you what is acute on chronic liver failure, and to impress upon you that the way we now assess patients with acute on chronic liver failure has been very well validated. We'll talk a little bit about the prognostic and the pathophysiologic basis of the disease as a basis of developing new therapies, but of course focus on the topic of general management. We can talk about potential new therapeutic approaches, and we'll finish with talking about how liver transplantation is now becoming an important treatment for these patients. So put the story into context, and I think it's really important for you to understand this because it goes to the heart of the issues we're dealing with in terms of classification of this disease. So here is David, who is a 52-year-old man who drinks excessive amounts of alcohol. He came to see me with alcoholic cirrhosis, but he was very well compensated. He was well at the time. He went away, continued to drink a little bit of alcohol, and he presented to the hospital about 4.5 years later with an episode of acute decompensation. And his acute decompensation on this instance was related to a pneumonic illness. He had high fever, leukocytosis, high CRP, ascites, and jaundice. And he came into the hospital with that acute decompensation, and within a matter of 4 or 5 days, developed this severe syndrome where he was progressively more encephalopathic. His bilirubin was high, INR was very high, and we diagnosed him with acute on chronic liver failure at that particular time. When you transition from this particular state of acute decompensation to development of 3 organ failures, and that's what I'm going to show you next slides. But before I go there, I think it's really important to understand where this sits in terms of the 3 major classifications that you might have heard of. I'm focusing, and for the rest of my talk, on the best validated of these, which is the Easel-Cliff criteria, which essentially thinks about organ failure at the basis of diagnosis of ACLF. The Basel criteria is based around the diagnosis being only jaundice with ascites, with or without hepatic encephalopathy, as the diagnostic criteria, but it does not include patients with previously decompensated cirrhosis, or those with gastrointestinal bleeding, or with bacterial infection. And if you use those Basel criteria, you would have thought that when he goes to the ICU, he would not have ACLF, and that's really important to understand. The NACSEL criteria was developed really in patients with infection, which really a Basel would not even recognize. That is specified that 2 organs, circulation, kidneys, and brain, and lung, the 4 organs. So if you see here, they left out liver, which is bilirubin and coagulation in the diagnostic criteria. So if you use the NACSEL criteria, you would have thought that our patient does not have ACLF. So fundamental differences between these 3 are really listed out there. So in the Easel-Cliff criteria is very inclusive. A Basel excludes patients, and so does NACSEL. The diagnostic criteria for ACLF is really encompassed within what we call the Cliff organ failure scoring system. And fundamentally, it's based around what we already know in patients with cirrhosis, that when there is very high bilirubin, or the kidneys start to fail, or the patients become very encephalopathic or very coagulopathic, develop circulatory failure or respiratory failure, they have increased risk of dying. And this has been shown in many, many, many studies. So there's nothing really new about it, apart from the fact that, as you can see here, if I divide the patients up into those without any organ failures here, the risk of 28-day mortality is very low. But if there are 1 or more organ failures, this increases progressively from 18% up to nearly 90% with 3 to 6 organ failures. So, and this is the failure of the organ criteria is just defined here. So failure of the organs, number of organs are associated with increasing the risk of death. But it's also important to understand that this syndrome is not fixed. It is dynamic. And this gives you the opportunity to interact with your patient in order to determine what the chances of reversibility of this disease condition is. And that's really defined in this diagram here. What it shows is that wherever a patient starts, they may have 1 organ, 2 or 3 organ failure. If they resolve their ACLF, absence of organ failures, their mortality risk is like that of a patient with no organ failures. If, however, they remain in the state that they're in, for example, if ACLF3 stays as ACLF3, then the risk of death remains extremely high. And the chances that they will reverse their syndrome is dependent upon the severity of ACLF at presentation. So final score is measured. The last assessment is day 5 to 7, and these are the scores at presentation. So It is really, really important that we get these patients early and intervene early in order to have the best effect. And the second thing about this slide is it tells you a little bit about reversibility and lack of regeneration, particularly in those with ACLF3. And this will come to light a little bit more as we move forward. So the diagnostic criteria for ACLF was really based around the canonic study. And again, this slide is only to show you that bacterial infection is a very important precipitating event for the occurrence of ACLF. And this is what this slide is looking at, precipitating illnesses leading to ACLF, which a PASL does not recognize. And the second one here is gastrointestinal bleeding as a precipitating event. And although it's not necessarily overrepresented, there's certainly a significant proportion of patients who present with GI bleed as a basis of development of ACLF. And that is what is trying to show here, that it is very clear that both GI bleeding and bacterial infection precipitate the occurrence of ACLF and are not necessarily a consequence as has been interpreted in other places. I just want to highlight a little bit more gastrointestinal bleeding and ACLF. And this is some recent paper from our own group where we looked at what determines the mortality of patients with cirrhosis in whom we cannot control variceal bleeding. As you can see here, it is really dramatic. In patients who have got the same severity of bleeding, the risk of death is related to the severity of ACLF. So here are patients with uncontrolled variceal bleeding and no ACLF compared with the patients here who've got ACLF3. So the severity of organ dysfunction is an independent predictor of the risk of death of patients with variceal bleeding. And therefore, these patients should be included in the diagnostic criteria of ACLF, which a PASL fails to do. This slide here is really just to indicate, I just wanted to focus here, which is the most important part of the story. In the PASL criteria, what we do is to exclude patients with previous decompensation as having any chance of developing ACLF. So they're excluded from the diagnosis of ACLF. But of course, you can see here that there is really no difference in those with previous decompensation and no previous decompensation. Nearly 30% of our patients had no previous decompensation, but 70% had a previous decompensating illness. And again, as you can see here, there's no difference in the severity of ACLF, and therefore to exclude patients with previous decompensation seems like an oversight, and we need to correct that as we move forward. Of course, we as academics and clinicians live and die by validation. So if there's a criteria for diagnosis and prognosis, it needs to be validated around the world. And that's what I show here in this slide. We published this paper not so long ago, but as you can see here, in the different colors are data coming from different parts of the world. So it's not a European disease. We have data here from Europe, that was the canonic and the predict studies, Asia, mainly from China and Korea, USA is large numbers of patients because there are large databases that function, and Latin America. So around the world, the findings of the Easel-Cliff criteria have been validated. And just to show you, different colors are represented here. What it shows is the prevalence around the world is very similar. 30% patients at presentation will have ACLF. Another 10% will develop it during hospitalization. The mortality rates at 28 days are very similar, 30 to 40%. At 90 days, 50 to 50 odd percent. And again, across the board. But what is really remarkable is that if you do not fulfill criteria for ACLF, then the mortality rates are dramatically low. So it separates out one from the other. And it is really important to understand that we should stop worrying about a PASL or NACSELD or Easel-Cliff. You go with the data that has been validated across the world. And this is what I'm trying to show here. So Easel-Cliff criteria has been validated worldwide. You know, whenever you have a syndrome which is newly defined. It's got a clinical characteristics, it's got a prognostic characteristic. The question is whether it has got any unique pathophysiologic phenomena. And that is what we found here. And this is really important because it goes to the heart of what we do for these patients now and in the future. And I'll just illustrate this to you just to show that the central underlying story, which has never been understood and never been recorded carefully, is what joins all these multiple organ dysfunction. And it is the severity of systemic inflammation. So patients may have hepatic encephalopathy or renal dysfunction or advanced liver injury or sarcopenia or immune dysfunction. What lies at the center of it is systemic inflammation. And that's what you show here, which is worse in patients with decompensated cirrhosis, acutely decompensated non-ACLF cirrhosis, compared with those with compensated cirrhosis. And in ACLF patients, it gets progressively worse. So as you can see here, white cell count, CRP, simple measurements were very dramatic differences. TNF alpha, IL-8, whatever cytokine is your pet cytokine you want to choose. Systemic inflammation is at the center of the story. Why it's important is really illustrated on this slide. But here is systemic inflammation. Okay? And so what we and others over the last 10 years have been trying to do is to try and understand why had these patients got systemic inflammation. Because if we understand why they have it, then they may become targets of therapy. And that is what new treatments in ACLF are based upon. So the idea here is that here is a patient with cirrhosis who's got pneumonia or acute alcoholic hepatitis. He has all these things going on here. They've got accumulation of pathogen-associated molecular patterns such as LPS. They've got damage-associated molecular patterns, which are products of cell death. They've albumin dysfunction, they're hyperammonemic, they've got metabolic dysfunction. What happens in the organs is they upregulate the inflammasome and the toll-like receptor pathways, because it means that when there is a second hit, like in our patient who got pneumonia, all these systems are activated, leading to this systemic inflammation, which results in organ perfusion problems, metabolic failure, leading to organ pathology and simultaneous or progressive multiple organ dysfunction and death. So therefore, what this gives you is a framework to develop novel therapies. And so you can treat the underlying liver disease, you can target cell death, you can target albumin dysfunction, you can treat hyperammonemia and the new drugs in development for that. For the inflammasome and the TLR4 side, you can use a TLR4 antagonist. You can use GCSF, which of course has not been shown to be useful, but clinical trials combining GCSF with TAC242 are underway. IL-22, plasma exchange, and new liver dialysis machines being developed, and liver transplantation, which I'll talk to you a little bit more about in the next slides. So many, many new therapies on the way. So the management of ACLF really relies on these 3 or 4 elements. It's solid intensive care. There's really no liver support device that is useful, so I'm not going to talk about it. And liver transplantation. I'm going to talk a little bit about the ability of ongoing care, and that is really important to understand. So I'm not going to spend a lot of time talking about the intensive care management, except to say that your team and your unit and your hospital needs to agree a path that you're going to follow for the management of these patients. You need to define the condition first, and you need to agree as to what it is that you're going to follow. And if you took my advice, you would follow the Easel-Cliff criteria for the reasons that I've laid out and what I'm going to say as we move forward. What about organ failures? How are you going to support the organ failures? And you need to set up your ICU such that you have different organ support systems available to you. You need to generate new protocols that allows you to manage bleeding quickly, infection quickly, what are you going to do with encephalopathy, how are you going to ventilate your patients, and so on. These patients need to be monitored because that's the only way that you'll understand what's going on with them. So what are you going to use for monitoring the brain, the kidneys, the liver, etc.? And this is a typical intensive care based program. There are many different things out there in terms of mechanical ventilation, which you need to decide. what kind of renal replacement you're going to use. Do you have plasma exchange, which of course is not the standard of care, but may be useful in certain patients. So it's doing stuff correctly all the time if you want to have reasonably good output and good effect from management of your patient. You know, one of the most emotive and the most difficult discussions that you have is that you've got a patient with ACLF 3 or 4 that's in the ICU. You've been supporting them for 3, 4, 5, 6 days. Transplantation, for whatever reason, is not an option in this particular patient. What can you do? It is extremely expensive, but also very distressing for everybody around. So the question is are there criteria that you can use that allow you to stop the intensive care support? And so we think the CLIF ACLF score, which is a combination of age, white cell count, and the CLIF organ failure score, you can use as a basis to start the discussions with the family that we can start to think about stopping ongoing intensive care treatment. And as you can see, if the score was above 100, the risk of specificity is nearly 100%. Whereas the score is greater than 65, the specificity is about 89%. So if the patient reaches a CLIF ACLF score, which is a score between 0 and 100 of 65 at day 5 to 7 of organ support, it is worthwhile initiating those conversations with the family to see whether you can set some stopping rules or non-escalation routes, which will allow for the patient the relief in a sort of a strange negative way, but also a futility of ongoing ICU care. But of course, this is very difficult, and these scores need to be validated in your country, in your clinical practice, as you know. Finally, and I think this is really important, because transplantation saves the lives of ACLF patients. But of course, in countries such as ours in the UK, and I'm sure in countries where there are cadaver organs available, even in living donor transplantation, there's always a question of equity versus efficiency. You don't want to transplant somebody who's so sick that they have a very high risk of dying. And conversely, you don't want to let a patient that can benefit from a liver transplant die without a transplant. So there is this dilemma, the yin-yang, that goes on all the time in these discussions. But I'll make a few important points. The first is, in a country like ours, in Europe and the US, where organ allocation, which is mainly cadaveric, is based around the MELD score, the question is whether it's appropriate or not. And this brings us back to the heart of the problem. Remember, the CLIF organ failure score, which defines ACLF, scores 6 organ systems. MELD score only includes elements from bilirubin, creatinine, and kidney. Bilirubin, creatinine, and INR, but does not take into account brain failure, circulatory failure, or respiratory failure. So it's not surprising to see that if you look at mortality on the waiting list for a transplant, you look at patients with, and you look at patients with MELD of less than 25, if they've got ACLF 2 or 3, the risk is extremely high, which means that MELD score underestimates the risk of death of patients with ACLF. And this is really important to understand. But of course, the bigger question, of course, is that if I took a patient with ACLF 3, multiple organ failure, then what kind of results do I expect post-transplantation? And that's what's shown here. The blue line here are patients with no ACLF, that's ACLF 1 and 2, and that's ACLF 3. And as you can see, even in these very sick patients with chances of dying of over 70%, the risk of the chances of 1 year survival is over 80%. So therefore, very clear evidence in selected patients of transplant benefit. And of course, you need to take out patients who are so sick that they're unlikely to benefit from liver transplantation. How is this being adopted in clinical practice? So one of the low ACLF transplanting countries in Europe are Spain and the UK, who have started to make changes. In the UK, there's an implementation of a new strategy to transplant patients with ACLF 2 and 3, and they now get priority. So the median time for these patients to get an organ now is 2 days, which is pretty remarkable, and we'll see how this program continues as we move forward. In Spain, there is now a new recommendation that these patients should be prioritized for liver transplantation. But of course, there are many questions to answer, and that is going to be addressed in this study, which is a global study, which is called the CHANCE study. And if any of your centers want to participate in this, please write to me, and we can see if we can include you in the study. So the CHANCE study is a global study, all the way from the West Coast in the United States, all the way to Japan and Australia, with many countries in the middle. So if you're interested, please let us know. So therefore, to conclude, Mr. Chairman, I think it's fair to say that the Easel-Cliff definitions and models have been very widely validated and is probably appropriate for patient stratification. Previous decompensation and infection as precipitating important components of AD and ACLF. So if you rule them out, you will miss patients with likelihood of dying. Systemic inflammation underlies the pathophysiologic mechanisms and is the basis of potential new therapies, and there are a multitude of new trials which are now undergoing. Liver transplantation saves lives of patients, and the current organ allocation policies are inadequate, and Easel-Cliff models are now being trialed as we move forward. So therefore, we believe that this is a new dawn for patients with ACLF as we move forward. I just want to thank the many fellows who have worked with me over the years and the people that provide us the funding for my research. So with that, thank you very much for this very kind invitation, and I'm happy to take any questions you might have. Thank you.
Thank you so much, Dr. Rajiv Jalan. And before we move on to our next talk of the day, if you have any questions from Dr. Rajiv, you can ask now from the live audience. Mike.
Leo, yeah. On. Hi, Raj.
Hello.
Nice to see you.
Nice to see you.
As usual, excellent talk.
Thank you.
See that the time in Edinburgh has been put to good use. Are you still playing squash or not?
Oh, very rarely.
Okay, so tell me, obviously there have been advances in this, but for resource challenged places like us, what would be the simplest test you want us to pick up? I take it MELT sodium would still validate for us?
Well, look, the point is about what it is that you're trying to diagnose, okay? So the diagnosis of cleft ACLF is only clinical, and very basic biochemistry is required. So if you can calculate MEL sodium, you can very easily calculate the CLIF scores and classify and stratify your patients into what severity of ACLF they have. And I think this is particularly relevant for resource-constrained countries such as Pakistan and India and the rest, and even in the UK, because what it does is, if you don't have ACLF, you know that these patients are unlikely to progress to requiring multi-organ support, and you can discharge them from the hospital early. The second is a patient who progresses to multiple organ dysfunction. The classification in this scoring system allows you to have conversations with the family to say that, look, it's very unlikely that this patient will survive, because the risk of death you can define using the CLIF ACLF score. And finally, it helps you to select patients for rapid transplantation if that is available to your patient. So at each of the three levels, it is particularly relevant for resource-constrained environments and a wider field. So I don't think that this concept actually implicates any problems with resource-constrained countries.
Okay, thanks.
Thank you, Rajiv, for a wonderful talk. I'm Dr. Altaf Alam.
Hello.
Well, I really like the easel cliff categorization and definition of ACLF because, as you mentioned, that 28-day mortality is so high in ACLF3, and you have such a little window of making that decision whether to go for transplant or not. And if you miss the boat, the important point here is that you need to start talking to the family and to the patients, relatives, that this is the mortality is very high, the escalation of treatment is not going to be productive, and you start thinking of moving the patient to palliative care. So I think it is very, very important, this point, and you have highlighted it very clearly. And for us here in Pakistan, where the transplant is not freely available, one should really identify these patients, de-escalate the treatment, and after talking to the family, and shift them to palliative care. So that will really save a lot of cost and distress to the patient, to the family, and to the treating physicians. Thank you very much for a wonderful talk. Thank you.
Thank you.
Okay, so if there are no any more questions, thank you, Dr. Rajiv. It was indeed enlightening. Thank you for your presence.
Thank you
Okay,
so much for the
so
invitation.
thank you, sir. Moving on to our last talk of the day and of the session also, which is avoiding and managing acute and chronic portal vein thrombosis in cirrhotic and non-cirrhotic patients, to be given by our very own Dr. Nadeem Tehami again, all the way from Southampton, England. And he's a very active teacher and a learner, especially when it comes to telemedicine. So Dr. Nadeem Tehami. We're going to start it now.
Assalamu alaikum. Once again, I would like to thank the organizers for their kind invitation. Title of my talk is Management of Acute and Chronic Portal Vein Thrombosis in Patients with Cirrhosis and Those Without Cirrhosis. In the world of hepatology, you will not find many topics where you will have an interest of a gastroenterologist, intestinal failure specialist, interventional radiologist, oncologist, and clever academics. And that is because the management may sound simple, but we know that in the clinical world, it can be really challenging. It's unfortunate that I cannot be with you. However, I send you Titanic greetings from Southampton, a city located along the south coast of England. It's only an hour's drive away from London. So if you happen to be around this neck of woods and we are out of COVID, then you're very welcome to come and visit us. My remit for this talk is to discuss the management with current knowledge in mind. I will try to keep the talk practical and will share some case vignettes. So when we talk about portal vein thrombosis, we try to differentiate or classify it into acute and chronic portal vein thrombosis in patients with cirrhosis and non-cirrhosis. But we also have to bear in mind that a major chunk of our work also involves those who have an underlying HCC. To keep it simple, patients with acute portal vein thrombosis can present as part of their inciting illness. They may or may not have signs to suggest mesenteric ischemia. Usually the precipitant is local or systemic. In cases of chronic, they can be asymptomatic or can present as worsening of their hepatic decompensation. In those with biliopathy, patient may present with cholangitis. In any case, it's really important that we differentiate or at least rule out underlying hepatocellular carcinoma. The diagnosis is mainly based on imaging. We ask for an ultrasound scan with Doppler of the portal vein. And if there is an absence or sluggish of flow, then that would make us think about the possibility of a portal vein thrombosis. We can always confirm it by doing a CT scan, which is usually required in cases where we have a high suspicion of hepatocellular carcinoma. So the first case is of a 68-year-old lady who had an underlying JAK2 mutation. She was well maintained on hydroxycarbamide and pegylated interferon for her polycythemia rubra vera. As a result of this, she developed portal vein and splenic vein thrombosis. She was warfarinized. She had evidence of portal hypertension. She unfortunately had quite an extensive past medical history, including ischemic heart disease, C. difficile associated diarrhea, and breast cancer. She was admitted with abdominal pain and distension, and initial blood tests showed that she was over anticoagulated. She had evidence of ongoing inflammation, as you would see with elevated inflammatory markers. Imaging demonstrated acute SMV thrombosis with small bowel thickening and ischemia. There was also evidence of moderate volume ascites, thickening of the cecum and proximal ascending colon. So the question is, how are we going to manage this patient who had an underlying chronic portal vein thrombosis with cavernous transformation? Very briefly, let me just take you through the anatomical grading. We know when the portal vein is excluded partially, that is less than this 50% of the lumen, we grade it as 1. In patient where there's occlusion of more than 50%, including total occlusion, they are graded as grade 2. Patient where there's an extension of the thrombus to the proximal SMV, they are given a grade of 3. Where there's an occlusion of portal vein and entire SMV, then they're graded as grade 4. Causes, we know about the local or systemic precipitant, including intra-abdominal infections. 50% patients may have an underlying procoagulant condition, and we know that about 25% we may not find the cause. Now, unfortunately, in this pandemic, we have seen patients with COVID who presented with portal vein thrombosis. And not to forget the data from Oxford, where they looked at nearly 5,000 patients and demonstrated that patients who've received mRNA COVID vaccine, the risk of portal vein thrombosis was 30 times higher. So acute portal vein thrombosis carries significant morbidity and mortality. In acute cases, we worry about intestinal ischemia, which could lead to intestinal infarction and eventually death from multi-organ failure. Patient could develop portal hypertension, which leads to further complications such as vessel bleeding and ascites. Based on the EASL guidelines, we screen for local or systemic causes. We start our patients with low molecular weight heparin and antibiotic if there's any evidence of ongoing infection or sepsis. Where there are features of intestinal ischemia, we consider further intervention, IR intervention, and rarely surgery. Where there isn't any, then we can start our patients of anticoagulation for at least 3 to 6 months. So the EASL guidance is to anticoagulate as soon as possible with unfractionated or low molecular weight heparin with the goal to achieve recanalization. So coming back to our patient, she was anticoagulated with low molecular weight heparin as per the EASL guidance. Now there are a number of studies which support that guidance, including this prospective study where they looked at over 100 patients and found that the recanalization rates achieved at 1 year were 38% in portal vein and splotches thrombosis, and was higher up to 60% in patients who have a superior mesenteric vein thrombosis. So our patient's thrombosis and SMV resolved. She was treated as type 2 intestinal failure with parenteral nutrition. Unfortunately, a few months down the line, she developed refractory ascites and was found to have a TI stricture causing small bowel obstruction. So our patient has portal hypertension, ascites, type 2 intestinal failure due to small bowel obstruction, and there was good going evidence of small bowel ischemia. What are our options in this case? Are we going to involve interventional radiologist or our surgical colleagues at this stage? So could we have done anything differently? or should we have thought of involving interventional radiologist or considered thrombolysis earlier? Now, as far as the evidence in favor of thrombolysis is concerned, let me share this study where authors were able to achieve 82% partial recanalization in patients who've had portal mesenteric vein thrombosis. And the complete recanalization rates were achieved in up to 41%. It was deemed as a safe and effective approach with low rethrombosis rates. Only 3 patients developed rethrombosis and 2 were due to interruption of the anticoagulation. They also did not observe significant bleeding rates, and other complications rate were also within acceptable limits. Participants required 3.5 CTs during the monitoring and management of their thrombosis. So the algorithm in the study was patients who've had an acute portal vein thrombosis with evidence of intestinal ischemia once they had ruled out the contraindication to thrombolysis, which I'm sure most of us are very well familiar with. They offered these patients IV alteplase followed by a dose of low molecular weight heparin. And these patients were monitored for bleeding from any site and also had regular blood tests. So following the systemic thrombolysis, these patients had repeat assessment with a CT scan after 48 to 72 hours of thrombolysis, or earlier if there was any other concern. If there was any evidence of ongoing intestinal ischemia or lack of improvement, if there wasn't, then these patients were able to continue treatment until the resolution for up to 7 days. And if there was any evidence of ongoing ischemia, then this group of the patient was further discussed with the interventional radiologist, and they were considered for TIPS or local infusion or local thrombolysis. On discharge, these patients were recommended long-term anticoagulations. So TIPS is certainly an option in this cohort of patients. Portal vein thrombosis is not an absolute contraindication as per the BSG guidance, which gives it a strong recommendation based on the high quality evidence. Now, recommendation that portal vein thrombosis cases should be discussed with centers with experience will not come to any of you as surprise. So she had TIPS in November 2020, followed by laparotomy, where the inflamed segment of small bowel was resected. There was also evidence of inflamed appendix. She required 2 further laparotomies to wash out post-surgical hematoma. In 2021, she's reasonably stable. However, she's now become institutionalized with low mood. She had further complications of venous occlusion likely to venous access. Her last CT scan demonstrated diffuse adhesions in encapsulation with irregular liver, which was not the case when it was viewed directly on previous laparotomies. Some of you would be keen to know what the histology was, which showed that she had active serositis with microscopic perforation in small bowel segment, and appendix also demonstrated active serositis with fibrous obliteration. So question can be asked, was it all triggered by an underlying appendicitis? So moving on to the portal vein thrombosis in cirrhosis, which is a commonest thrombotic event. It can often be asymptomatic in up to 50% of the cases. Symptoms typically include portal hypertensive bleed or abdominal pain. Worry here is again extension into SMV, which could then lead to intestinal ischemia and infarction. There is a data out there which concludes the negative effect of complete portal vein thrombosis on the post-transplant outcomes. The treatment options include anticoagulants and interventional thrombolytic therapies, which are often chosen on case-by-case basis, and it depends on the characteristics of the patient and the thrombus. Professor Garcia and colleagues have published a review in Journal of Hepatology recently, which outlines the risk factors for portal vein thrombosis and cirrhosis. It highlights the importance of etiology of the cirrhosis, Child-Pugh class. It also provides us with some practical tips For example, looking for presence or absence of clinically significant portal hypertension when we are reviewing the patients in the clinic. Whilst reviewing their ultrasound Doppler portal vein review, we could look at the flow in the portal vein, and if there's a previous history of any surgical or interventional radiology procedures. Let me share this very interesting study where authors prospectively looked at 369 cirrhotic patients without portal vein thrombosis. These patients were followed up for 48 months time period, and patients who developed portal vein thrombosis in this time period were further analyzed for the risk factors for portal vein thrombosis. Now, it would not come to you as a surprise that the markers of portal hypertension were regarded as strong predictors for portal vein thrombosis. However, markers for thrombophilia, acquired and inherited disorders, and beta blockers were not regarded as significant predictors. We cannot complete this talk without discussing briefly coagulation in cirrhosis. I'm sure you all appreciate that the balance between procoagulants and anticoagulants is maintained in patients with cirrhosis despite reduced production. This balance, however, can be tipped in one or the other direction. That is, patients with acute decompensation can develop significant bleed or DIC, which could be precipitated by underlying infection or uremia. With the similar circumstances, the patient could develop either peripheral or portomesenteric thrombosis. Although we won't have time to discuss portal vein tumor thrombus in detail, however, this is a question which gets asked frequently, especially in patients who have an underlying or associated hepatocellular cancer. So based on the available evidence, presence of 3 or more of the following could predict HCC-related portal vein thrombosis with a very high sensitivity and specificity. Let me take you through this case of a 58-year-old man who had a transplant for Hep C and alcohol-related cirrhosis. He developed cirrhosis in the graft after he started drinking again. He presented with GI bleeding and easy bruising. Blood tests showed low platelet and hemoglobin. His GI investigations were unremarkable. He was referred to hematologist and was diagnosed with ITP, which unfortunately did not respond well to steroids and IV immunoglobulins. His treatment was escalated. However, he represented a few months down the line with further episodes of GI bleed and subdural hematoma and low blood indices. His investigations were repeated, which were again unremarkable, and then he was started on eltrombopag, which is a prothrombin receptor agonist and increases the platelet production after binding with the receptors. Now, unfortunately, this nicely designed study was terminated early after thrombotic events were observed in 6 participants of this study. Our patient presented a few months later with acute onset abdominal pain and vomiting. He was covered in bruises and was tachycardic on examination. His blood tests showed elevated inflammatory markers, low platelet count. His chest external bronchoscopy was unremarkable. He was admitted to acute surgical unit and an urgent CT scan was performed, which I'm sure you would all appreciate shows this massive thrombus in his portal vein. Now, we discussed the case with hematologist who advised to give him platelet transfusion with high-dose steroids and IV immunoglobulins, and we continued with his eltrombopag. He was also given IV heparin after his platelet count were above 50. Now, at this stage, we discussed his case in our transplant MDT, where unfortunately he was not deemed suitable for retransplantation for several reasons. Our patient remained on IV heparin, however, his abdominal pain did not settle despite achieving a stable platelet count. So we repeated a CT scan, which unfortunately showed progression of his thrombus. We discussed him again for transplantation, however, decision remained the same. We were rapidly running out of our options, but where there is a vessel, there is a way. He was then offered thrombectomy, put back on IV heparin, and CT 24 hours later showed significant resolution. He was then offered TIPS. So we know that TIPS with or without thrombectomy is feasible in most cases and reduces the thrombus burden. It is generally reserved in patients who do not respond to 6 months of anticoagulation. It could be considered as first line in the presence of significant complication of portal hypertension or thrombus in a transplant candidate, or if there are any contraindication to anticoagulation. Our patient developed a further small complication, i.e. a hepatic hematoma following TIPS, which required embolization. This resolved his abdominal pain issue and he was able to eat better. Later on, he developed a right leg DVT on IV heparin, which was diagnosed as HIT. He was put on argatroban infusion for a week and then converted to fondaparinux. He was managed quite closely with our hematology colleagues, and we were able to discharge home a few weeks later. Professor Garcia and colleagues recommended this logarithm in their recent review, and exactly what we had followed whilst managing our patient. A brief word on anticoagulation in portal vein thrombosis. We are all aware and familiar of available formulations. DOACs are being increasingly used in patients with portal vein thrombosis. They are safe and effective in those who do not have underlying cirrhosis. Data is, however, emerging of their use in patients with early cirrhosis. They are administered orally once a day. Dose changes are not required with all formulations. For example, dabigatran apixaban does not require dose changes in patients with renal impairment. The absorption does get affected in patients who have edema and ischemia. Monitoring is not required, and antidote is unfortunately not available for all DOACs. Bivino 6 consensus recommendation focus mainly on the management of patients who are on liver transplant waiting list, and it encourages early anticoagulation to facilitate transplant and reduce post-transplant mortality and morbidity. In patients who are not offered anticoagulations are recommended to have an early imaging follow-up. The same recommendations are not made made for patients who are not on liver transplant waiting list. Now, unfortunately, I don't have enough time left to take you through one of my most favorite slides of this presentation. However, it's encouraging to see data coming out from transplant centers of Pakistan, where we are pushing boundaries and offering transplants in patients who would otherwise not deemed suitable for transplantation in maybe some other systems. So in conclusion, ladies and gentlemen, chairpersons of the session, time is everything. If we lose time, we lose enterocytes in patients who have acute portal mesenteric vein thrombosis. We should not delay our intervention, discuss with our colleagues and MDTs given the uncertainties in the management. We should also try not to delay anticoagulation, especially in patients who are on liver transplant waiting lists. Thank you for listening, and I will look forward to your question and answer session.
Thank you, Dr. Nadeem, once again. Crisp and up to mark as it could be. For question answers, I think Dr. Nadeem is live with us. Can you hear us? Dr. Nadeem, are you there?
Okay, it seems that remains for me to thank all the speakers. They are wonderful talks. Given so complex, remember this take home message: the termination of pregnancy or fulminant liver failure in the third trimester in pregnant women is not the standard of care so far. So the jury is still out. You may choose to do that, but majority of the centers worldwide are not practicing it. So that is one thing. The other thing is
hepatitis E vaccine is available in Pakistan, so you can consider it in established indications. Certainly not in pregnant women, not in children, but women of childbearing age, patients with chronic liver disease, elderly. So these are the people who are more exposed and prone to have complications from hepatitis E.
Okay.
We have already talked about ACLF. And if Nadeem is here, Nadeem, oh, Nadeem is here.
Yes.
So if there are any questions for Nadeem Tehami, they can be taken directly by him. My question to you, Nadeem, many patients in Pakistan with cirrhosis, decompensated cirrhosis, who are not transplant candidates. They can not afford it, they don't have a donor, or they don't wish to go for transplant. So whatever reason, they are not candidates for transplant. Would you still anticoagulate them if they have portal vein thrombosis of grade 2 or more? Yes or no?
Simple answer is no. No, I think you can argue both ways, but if you purely look at the guidance with the Baveno classification between the last 6 months, the recommendations were most focused on patients who were either deemed suitable for transplantation or were on liver transplant waiting list. Those who are not, and we know even from the evidence, both in the liver and the pancreas world, that they, by the time they get to that stage, or by the time they get diagnosed, most of them have established collaterals. And I think in that situation, they've got all these shunts all over the body, and we know how these patients behave. So we tend not to, if we can avoid. The only concern is if there is any portomesenteric thrombosis, which seems to be progressing. So whenever we diagnose them, I mean, whatever stage they may be, we say cavernous transformation is a marker that patient may have a chronic portal vein thrombosis, but we also know, and we've seen it in patients developing that within kind of first week of presentation. So it can be seen between 6 to 20 days. So that is not an indication that patients is a long standing. So our point 0 should be when we diagnose them. If there is any worry about portomesenteric vein thrombosis, you need to liaison with your radiologist. And if there is any evidence of bowel ischemia, mesenteric ischemia, then I guess you don't have any option but to consider anticoagulation this patient. But if they are not deemed suitable for any escalation of care, and if you're just focusing on tender liver care, then I guess I don't see there's any point in subjecting them to another anticoagulation. And then you have to juggle whether this patient is going to bleed or clot is going to get worse. What's the risk of GI vessel bleeding? So all those factors come in. But I think one thing I would say, this is a group of patients which I think we should not manage alone. We should try to manage them with radiologist and hematologist. With all due respect, I don't believe we understand the clotting process in liver disease better, and I also don't believe that hematologists entirely understand this this problem. So it has to be a collaborative approach when we are faced with any such scenarios.
Thank you very much, Nadeem. Final comments from my friend, Professor Naseeb, and then we'll close the session. Naseeb?
Nadeem Tehami, it was a nice presentation. We really liked it. But during you have not mentioned as another DBT, we go for looking for some other deficiencies, protein C, S, and other factor. So is there anything like that you have gone through? And you haven't mentioned the percentages, as you have said, 25% idiopathic. What about the other percentages? And what should be the priority for anticoagulation? As we are careful, the COVID is very common these days. So people also get, so regarding anticoagulation, so what precautions should be taken?
No, I mean, I wish I can answer this question. To be honest, you've rightly said that there's up to 50% may have an underlying procoagulant condition. But the problem is once we have anticoagulated or they've already been warfarinized or put on any anticoagulants, and we probably have missed that board. So it has to be done either if it's we believe it's a temporary event and they can stay on anticoagulation for a definite period of time, and then that needs to be checked that they have an underlying procoagulant condition afterwards. So while they are on anticoagulation, I don't think you can really assess them correctly correctly. With regards to COVID, again, I have literally, I've begged my colleagues around me and I've said, look, guys, can you be on the forefront and let me just stay in the back? I've been extremely worried myself. I mean, I don't have much of understanding, knowledge of COVID. As I said to you, as I shared that Oxford data with the patients who have received mRNA vaccine with the Pfizer and the Moderna, their conclusion was 30-fold higher risk of developing thrombosis. So it is a challenging and mind-boggling area to be able to comment. And as I said, I wish I could answer this. What was the other thing? So you mentioned about the procoagulant and checking for DVT, and yeah, so looking for the underlying procoagulant causes.
Thank you
I
very
hope
much.
this answers your question.
Over to Najmul Sir to close the session, please. Thank you.
Thank you so much, Professor Altaf, Professor Amir Ghafoor, and Professor Nasibullah, and all the speakers for the wonderful session. And thank you all for being here. And this brings us to the end of the session. After this, we are going to have a short break for Maghrib, and then there will be a workshop regarding the research. Okay, thank you.